Question I get asked a lot, both by patients and healthcare professionals, is what is the best sclerosant? In this video, I will be joined by an expert, my colleague Richard Oliver, and together we will answer this question. My name is Dr. Haroon Gadraj, Director of the Vein Care Academy, helping doctors and nurses by providing online learning courses. Now, if you're new here, please make sure you click that subscribe button and all the links in the video description box below. So let's get started and stay to the end where I will share with you a resource I've put together with Richard Oliver. Be warned, this is probably the longest video I have done, and it is a measure of how interesting I find this topic, and I hope you find it interesting and helpful too. Today I'm going to talk to Richard Oliver about sclerosants. Sclerosants are one of those topics that always cause a heated debate amongst practitioners. What is the best sclerosant? What concentration should you use? If you do dilute it, what should you dilute it with? And how you should inject it. So I've known Richard for many years. He's been my go-to source of information. He's helped me with sourcing a number of difficult to get hold of scientific papers, and I've always found him to offer a very balanced view about sclerotherapy, sclerosants. When he wants to express a personal opinion, he'll say it's personal and he doesn't have any evidence, or it's sort of maybe biased, but where there's evidence for and against, I know Richard always provides the evidence both for and against. So Richard, just tell us a little bit about yourself for those who don't know you.
Right, thank you, Haroon. I work for a company now called Limco, which previously was STD Pharmaceutical Products, who are the manufacturer of Fibrovein, one of the sclerosants that we will talk about today. It's no longer part of this company because it was acquired by an American company, Merit Medical, about 2 years ago. Whilst we now still continue to do some services for that company, it doesn't belong to us any longer. I've worked for this company for around about 6 years. Prior to that, I was a dentist and a specialist in oral and maxillofacial surgery, actually, and a consultant and senior lecturer at the University of Manchester for a good many years. And prior to that, I did spend 3 years training to do pathology as well. So I've got quite a lot of scientific and medical background, which has been very helpful for this job in terms of understanding everything about it. So, as I say, although I'm from a company, I'm not going to be partisan today. I like to present, and I like to know, and I always have liked to know the science behind things, where it is available, and we'll talk about that today. Unfortunately, there are some areas that are not available, so we have to go by sort of learned opinion, which we will discuss as things go on.
Right. Well, thank you, Richard. Let's dive straight in. We've got a lot to cover. For those who are listening and want to know the running order, we're going to talk about sclerosant types, which are used for veins in general, but we're going to concentrate on microsclerotherapy, by which we mean the injection of prescription medicines into small veins, telangiectasia, up to 1 millimeter in size, and reticular veins between 1 and 3 millimeters in size, affecting the leg. We're going to talk about how the sclerosants work. There's several classes, but we're going to classify the 3 major sorts of sclerosant. The 2 most popular sclerosants worldwide are Sodium Tetradecyl Sulfate and Aethoxysklerol, or Polidocanol. They're both detergent sclerosants, and we're going to talk about the comparison between those 2. We're going to talk about who might be suitable for sclerotherapy, needle sizes and types, whether we ought to be using liquid or foam sclerosants for microsclerotherapy, some of the side effects, pigmentation, phlebitis, matting, the possibility of intrarterial injection, which is obviously a catastrophe which we want to avoid. We might cover briefly anaphylaxis and serious reactions, because one of the arguments that some specialists put forward for using hypertonic solutions such as dextrose or saline is that they avoid that, and we'll talk very briefly about that. What we should say to our patients after microsclerotherapy, what sort of aftercare instructions and advice we should give, and then a topic which I know Richard knows a lot about. I've been taking photographs for quite some time now, and we'll talk very briefly about the utility of a photographic record. So, Richard, let's dive straight in then. Sclerosant types. There's more than one type, isn't there? There's a classification system which we often use.
There isn't, I wouldn't say necessarily a formal classification, but there are a number of products that are used across the world for the purpose of sclerotherapy or sclerosing. When we're talking about veins, they're broadly three categories, but there are other chemical substances that are used as a sclerosant, such as alcohol, absolute alcohol, phenols, tetracycline, and some things like methotrexate. They're used for generally vascular malformations and that sort of thing. But when we talk about veins, broadly speaking, what I would always categorize it into three groups. So we've got the detergents, which you've just talked about, which are really sodium tetradecyl sulfate, STS is easier to say, is what most people abbreviate that to, or Polidocanol. We've got a group of solutions called hyperosmolar solutions, which you've briefly touched on there, and then a third group called chemical irritants. Those are the ones that have only ever really been used and reported to be used on veins in recent history. I think going back in time, people have tried to inject all sorts of things into varicosities to see if they're going to work. And it still surprises me that someone thought, oh, let's get some soapy solution and inject that into someone's varicose veins and see if that works. But how things happen is another story.
Yeah.
So we are going to concentrate. Sorry.
Yes. Sorry, go ahead, Richard.
I was going to say, we are going to concentrate on the detergents and talk a little bit more about those. But I don't know whether you wanted me to talk about the hyperosmolar solutions just now.
Well, they're quite popular in South America and some parts of Europe, aren't they? The dextrose 75% or the hyperosmolar hypertonic dextrose solutions. They are used, I know, in South America. There are some specialists that use it in combination with laser, for example, and they claim that it avoids a lot of the problems that are associated with other sclerosants, such as pigmentation. Certainly, it seems to avoid completely the risk of anaphylaxis. That's quite rare, I know, but it's one of the dreaded complications. I've never seen it myself. It is very rare, but obviously if it were to happen, it could be life-threatening. So those are the arguments for using those. We don't use it in the UK at all, do we?
No, I mean, there are no such solutions licensed for that purpose. It does tend to be an American, I think even in some parts of the United States of America, they are used, but off license and often as a compounded product. So that's where a pharmacist, like they used to do in the UK many years ago, you could go to a pharmacy or a chemist on the high street, because they'd have bottles of solutions on the shelves, and they would make a solution up for you. But they work on the basis of you're injecting a hypertonic or a hyperosmolar solution into a blood vessel, and we know from biology and physiology that we'll have learnt over the years that whenever you've got an osmotic gradient, water will always move towards the higher osmotic concentration, and so that they're thought to work by essentially dehydrating the cells and killing them in that way. They are reported to act a lot slower than detergent solutions. I've read some reports that have said it maybe take 20 to 30 minutes for them to actually exert their mode of action, and very attractive because essentially they are it's physiological products that you're injecting into somebody, but they're not without their issues. I mean, people who've worked in hospitals will be familiar with products. You can prescribe 50% dextrose for people who are particularly low in sugar, but the instructions are quite clear on those sorts of products. You don't inject them directly into a vein because it will cause all sorts of issues that we will talk about in a moment. So they should only be injected into central lines, for example, and also diluted down from the 50%. And there are all sorts of concentrations used from about 10% up to, as you say, 75%. A product that I think I had a check before we came on the call, Sclerodex, is still manufactured in Canada.
Yes.
And I think that's 25% glucose, 10% saline.
Yes.
The way that the way to think about it is if we just want to go back to the science, is the osmolality of plasma. So osmolality and osmolarity are similar terms. They sort of describe the amount of solute in a volume of liquid. But osmolality is the one that's used in biological terms. So the osmolality of plasma is about 275 to 300 milliosmoles per kilogram. The osmolality of, say, a 25% solution of dextrose is about 1,000.
Right.
And of 50% glucose, it's about 2,700. So it's vastly different to what the plasma is like. Whereas you will find that the osmolality of or pretty much any injectable drug is always going to be as close to plasma osmolality as possible, and certainly no higher than 1,000, but around about the 300 mark is considered ideal, or less than that. What is often described in many of the papers that are on this, and there aren't vast numbers of papers on hypertonic solutions, but they're said to be very painful when you inject them, mainly because of the effects they have directly on the blood vessels, but also on the nerve endings, and also sometimes on the overlying muscles or the underlying muscles, depending on where the pain is. And they can quite often cause muscle cramps because of that high osmolality in the solution.
Yes.
So the third group is chemical irritants. So those are products that literally are just noxious to cells. And the one that has been the most popular across the world is a product that's chromated glycerin.
Yes.
And the best known brand of that is Scleromo, which was made in the European Union. It's a 72% solution of chromated glycerin. So they have to be quite concentrated solutions to exert their effect. It's a very gloopy solution. I don't know whether you've ever seen it. It's a very
I've never seen it.
Very thick. It's like syrup. It is really thick compared to the solutions that you're used to using on veins. So handling of it is quite difficult. But the practitioners I've spoken to that use it say that they get very good results with it once they've got over the learning curve of handling this very thick, viscous solution. It's not currently being manufactured anywhere in the world because also there was a Canadian company making it as well. And I checked this morning, they're no longer making it either. As a company, we used to distribute Scleromo along with Polidocanol and Fibrovein. Probably about 3 years ago now, we were informed that the supply was going to be interrupted. And the only information that we've learned is that the product that was being manufactured was not actually up to current pharmaceutical standards. And we've not seen or heard anything further that there's any intention to produce it again. So I think that may be more of historical interest now and may not be available again. So those are broadly the three groups, and we'll concentrate more on detergents, obviously, because those are the most widely used across the whole of the world and the most widely available commercially in a pharmaceutical form that is safe to use on patients.
Right. Well, as I said in the discussion just before we started the recording, Richard, at any conference or at any meeting, if you discuss what sclerosant you use, you'll get a lively debate about which sclerosant they use and which is the best. Now, as you've said, detergents worldwide are the most widely used. I think in the UK, only STS and Polidocanol have a license to be injected. So as far as we're concerned in the UK, those are the only two we should be using. It probably is unacceptable to use any other sclerosant in the UK. And I think the situation is probably the same in Europe and North America. Do you think that's fair to say that people would be using either STS or Polidocanol?
Yes, I think that is fair to say, and I think in the medico-legal climate
Yes,
that we're in,
yes,
if you were to have an adverse reaction that was significant and it went further and there was a complaint raised against you,
yes,
and you would use an unlicensed product when there is a perfectly there
yes,
are perfectly good licensed products available in your market
yes.
area, you would have a lot of difficulty defending that
Eh,
if it got to a court of law. Yeah.
yes, be difficult. Right, so the two-horse race is Polidocanol and STS. And I have to say, I've been through both. When I first started microsclerotherapy in my practice, there was no licensed product. The only thing that was really available was Sclerovein. It was manufactured in Switzerland, I understand, I believe, and it was licensed. It wasn't licensed to be used, but um, by convention, it was regarded as the best sclerosant. Um, then I'm not sure which year it was. Was it 2012? 2012 that STS got a product license for the use at the 0.2% for telangiectasia and reticular veins. So it became the only licensed product for treatment of small veins. And then because of the regulatory environment and for the medical legal reasons that you have just mentioned, I stopped using Sclerovein and started using Fibrovein. Now, I think 2 years ago, we have another licensed product, Aethoxysklerol, Polidocanol. So we've got those two now to choose from. They're both detergents. There seems to be some confusion about whether they really work in different ways and whether they have a different safety profile. Well, what's your view of that, Richard?
Okay, so they are both detergent sclerosants. Um, one of the big difficulties that everybody's had over the years is in terms of objectively measuring and observing how sclerosants exert their mode of action. But there is a reasonable amount of certainly in vitro data that has shown how they work. And whilst they are both detergents, they work in a broadly similar way. So there are some subtle differences because they are different molecules. Um, the SDS originates from the optical industry, so is used for cleaning high grade glassware, sort of telescopes, camera lenses, that sort of thing, to a high level. Whereas Polidocanol originates in the dry cleaning industry, so it's used as a dry cleaning detergent.
Yes.
Hence the reason why Chrysler, who make Aethoxysklerol, another arm of their company is in dry cleaning chemicals. So that's a
Right.
big area of their company. Broadly, I mean, do we want to talk about the mode of action of detergents?
Yes, yes, yes. That'd be good. I mean, I think ultimately the final common pathway for all sclerosants is the same, isn't it?
Oh
You,
yes, yes.
yes. So they disrupt the endothelium and expose the media, and they start a process by which the vein forms a sclerothrombus and then closes and eventually occludes. But the way in which the three categories, which won't go into chemical irritants and hyperosmolar, but the way that both Fibrovein or STS and Polidocanol work is the same. And the mechanism on the endothelium is a detergent action, isn't it, Richard?
Yeah. So when I try to explain this to people, because it's not rocket science by any means, but it requires going back a little bit in time in terms of people's history, back to chemistry at school,
Yeah.
learning how soaps and detergents work.
Yeah.
And the reason why we use soaps and detergents on a daily basis is because they're very good at absorbing fats and removing fats from things. So
Yes.
we soak our dishes in the sink, or put soap
Yes.
in the dishwasher, or we get in the shower or the bath and use soapy detergents to help clean the fatty material from our bodies or dishes. So that's the way in which they're primarily working. So they form a micelle structure, which is a spherical structure when they're in a solution of water, and each individual detergent molecule has a hydrophobic end and a hydrophilic end. So the hydrophobic end is like a tail structure which points to the middle of this micelle, and the hydrophilic, the water-loving end, points towards the outside of the structure. And in that micelle, it's very active and able to absorb fats from any that it comes into contact with. So as soon as a detergent molecule comes into contact with a cell, which has a very similar structure because it has a phospholipid bilayer forming the cell membrane, with the phosphate group pointing out towards the water and the lipid tail going in towards the center of the membrane, and that's mirrored on the inside of the cell. It will start to absorb the fatty part of the phospholipid by inserting individual molecules into the cell membrane and essentially sucking up the fat structures from there. But it's also been observed, and Courage Parsi has got some good papers on this, that it emulsifies the proteins. So basically the detergent molecules surround the proteins that are in the crossing the cell membrane or in the outer cell membrane or in a part of the cell membrane. And once you've broken the integrity of the cell membrane, the intracellular contents get exposed to the extracellular environment. Straight away, you're going to incite an inflammatory reaction. Because it's also in a blood vessel, and the various, and that's taking me back. I won't be able to tell you the precise protein structures that stimulate the platelets, but that's going to stimulate the clotting cascade and the platelet aggregation, and you will get a thrombus forming at the site of the destroyed endothelial cells. And as you say, that then goes on to become organized and repaired, or basically healed by a scar. And that's the desired end outcome of sclerotherapy. So the two molecules, Polidocanol and STS, work in a very similar way. There are slight differences in the structure. Polidocanol is said to sort of punch holes in the membrane, whereas STS sort of rips bigger chunks of the membrane out. I don't think anyone can really say that with absolute certainty, but these are the theories that have been put forward in terms of exactly how they work.
Right. So we're all familiar, everyone is familiar with detergents. As you say, we use them to wash up the dishes and so forth. And I think that it's interesting to note that when you, some people are trying to decide whether to store their detergent Sclerosant in the fridge or whether to keep it at room temperature, whether to warm it. We think that actually that these detergents are more likely to form active micelles at room temperature rather than being stored at a cold temperature. So they're best stored at room temperature.
Yes, absolutely, because I mean, the micelle formation is determined by the concentration of the sclerosant in the solution.
Yes.
And there is what's called a critical micellar concentration,
Yes.
above which the majority of the molecules then will be in a micellar form in the solution. Although they don't stay in a rigid micelle all the time.
No.
It's a fluid process whereby the molecules exchange, but with the free molecules in the solution, and it's an active fluid process that happens throughout the life of the solution. We know that when we wash up at home, we'll get better cleaning ability if we use hot water than if we use cold water. I don't know whether anyone's tried washing up with cold water, but it's not as effective as hot water.
No.
But that's just the nature of that detergent. If we were to cool STS or Polidocanol in the fridge, then there's more likelihood it's going to fewer of the molecules will be in their micellar form.
Yes.
And the storage temperatures for both products are sort of ambient room temperature, below 25 degrees. Below
25, yes. Interestingly, I was told an anecdote that when you put your dishes in to soak, if there's they do dissolve the fat, but if you leave them overnight and come back in the morning, then all the fat is still on the layer of the sink water. So
that's right. Yes.
So wash up while it's warm and don't leave them to soak overnight, because if you do, the fat will just come out of solution again as it becomes cold. So that's just
good housekeeping tips.
Good housekeeping tips for detergent sclerosants discussion today. And so if they both work as sclerosants by disrupting the cell membrane and their detergent action is fundamental, why is there perceived to be such a big difference? Is it the Is it the length of the molecule? Is it the molecular weight? Is it the concentration strength? Do you think there is a real difference, or are we just talking about?
Yeah, there is clearly a difference in the two molecules. Essentially, STS molecule is about half the molecular weight and half the length of Polidocanol. Poly, because it is sort of like is a polymer really of lots of hydrocarbon chains. It's a very long molecule. STS is charged at the head, so it's got a charged head, whereas Polidocanol is neutral. Not that I don't think that really has a huge difference in its detergent action necessarily. But there is a clear difference in the potency of each of the two products when used at equivalent concentrations, and that's the most important difference that people need to realize, because everyone accepts that people will encounter and will use probably over their lifetime both products for whatever reasons, whether that be availability or whatever's used in their clinical environment. And I think most people would honestly say that the actions of the two clinically are broadly the same, but the potency is very different between the two. And we don't know precisely how to explain that, because I said a moment ago that it's very difficult to objectively measure how much action a detergent is making towards a cell, because there's no way of measuring that particular chemical process. But based upon the observations of very many people over very many years, the conclusion is that STS for any given concentration is about twice as potent in terms of its detergent action as Polidocanol. So, for example, if someone was going to use 1% Polidocanol, then they should use 0.5% STS, because those would be equivalent in their detergent action.
Yes.
Now, one way that has been postulated to us to explain it, because although I'm not a chemist, I did A-level chemistry and decided to leave it there and not pursue it anymore, but the molecular weight of Polidocanol is about twice that of STS.
Yes.
So in any given percentage solution of the compounds, you're probably going to have approximately twice as many STS molecules as you are Polidocanol. And that is probably the best explanation that we've managed to come up with so far.
Yes. One that I think that is probably how I view it. Whether it's the right explanation, I don't know. But when we talk about percentage, we're talking about weight per volume, whereas we're not talking about molar concentration, the number of molecules per given amount of solution. So I think that's how I think about it, whether it's correct or not. So the potency is different because the STS molecule it has a lower molecular weight. So for any given amount of percentage solution by weight, you're getting more molecules, more active molecules. And presumably, what about the propensity to form micelles? I know very low concentrations, Polidocanol still forms micelles, whereas I think the minimum critical concentration for STS in water for injection is only 0.2%, isn't it? So
yes, that's right. So the critical micellar concentration of Polidocanol is very low, and I can't remember.
It's got a lot of 0.000
a lot of zeros.
Yeah.
Whereas for STS, it is 0.2 when it's in a solution of water.
Yes.
If it's in a solution of saline, then it's 0.075%. So
yes,
less than 1%.
Yeah.
And the only real relevance of that clinically, and again, it's never really been proven that that's the case, but it's what we would normally always recommend people. If for some reason they need to dilute the 0.2% STS, maybe for really fine spider veins, when it might be indicated that 0.1% is a better concentration, then you would prefer to dilute it with saline rather than water, so that you can ensure that the molecules are in a micellar structure in the solution that you're injecting.
Yes. Now, one other thing that's been of interest is that on my discussion group that I have, we were talking about a temporary interruption of supply of 0.2% STS, and a colleague suggested that if you get the 3%, you could dilute it right down to 0.2. Would that be something, I don't want you to say, yes, you think that's a good idea, but is that acceptable when you've got an interruption supply? Can you dilute 3% with saline down to 0.2? Would that be appropriate? Or is that a contravention of the product license?
It is against the license, so it would be, you'd be using it off license, off label in that indication. However, that said, there are many markets in the world where only, particularly in 3% is the only one that's available. It's the only concentration that's available, largely through historic reasons. So Australia and South Africa, for example, those were licensed way back in the 70s, and the licenses have never been updated to include the lower strength. So they've never been available, although they are available now in Australia, but still the doctors prefer to dilute it down.
Yes.
So where there is a genuine lack of supply of a concentration that would normally be in the marketplace, and I think that you could defend that. It's all about really these days defending your practice should anything adverse or untoward happen. So it is done. It is possible to do. We tend never to recommend people do it. Well, we would never recommend someone to do it where there is the licensed product is available in their market, because that's why there is a licensed product there, because it's been produced at that concentration, because it's indicated for that size of vein treatment. What we find, and I don't know what your experience is, but the only doctors that are really good at diluting parenteral drugs are anaesthetists, because they're quite used to doing it on a regular basis and have to do it regularly. If you hand a doctor a vial or an ampule of a parenteral drug and say dilute that down to 1 in 40 or something, they'll look at you like you're talking from another planet.
Yes.
They don't like diluting drugs generally, unless it's something that they're used to doing. So if you don't dilute something properly, then you run the risk of either over diluting it and therefore reducing its efficacy, or under diluting it and using too strong a concentration and risking the adverse events that might result as a result of that. We do have a chart for countries where it is common practice to dilute, and it just has to be done carefully.
Yes.
So you're just doing it so that it remains safe. What we would always say for anybody who dilutes, well, not just a sclerosant or any product, in the actual vial or ampule of product that you receive is not just the active ingredient, not just the sclerosant, but there are also buffers in there that help maintain the pH at a set range, so that it doesn't exceed that pH range.
Yes.
And also, largely now historically, but it still is in the product, there will be a preservative.
Yes.
So in STS, it's benzyl alcohol, for example.
Hmm.
And if you dilute a product, you're also diluting the buffers and you're also diluting the preservative.
Right.
And as long as you use that product straight away, then not an issue. But what you don't want to do is store that product diluted. One, because there's a risk that the pH could change, because the product could potentially degrade and the pH could go out of its safe range. But more importantly, if you dilute the preservative, then you'll run the risk of particularly endotoxins accumulating and injecting microbial products or endotoxins into people, which won't be very nice. And that's one of the issues that they have in India, because there is a licensed product in India called Cetrol, which is an STS product, but it only contains STS and is diluted with water for injection, and that's all there is in it. And quite a few doctors have reported to us over the years that when they inject their Cetrol into patients, whether it be for spider veins or for large varicose veins, they do frequently observe quite adverse skin reactions around the site of injection, and other adverse reactions, which are probably as a result of it having no preservative in and no buffers to maintain the safe pH range.
Right. Okay, well that's very interesting. I'll put my hand up and say that routinely I do use 0.1% STS. I arrange for it to be diluted with an equal amount of normal saline. So it's a simple maths
That's a
problem.
simple dilution.
That's
Yes.
a simple maths problem. And also, I'm very fortunate in my clinic that I'm always with a qualified healthcare professional who can check the expiry dates and the volume. So I don't draw up drugs, dilute them, and inject them myself without reference to somebody else who's checking, because of the reasons you've just mentioned. Now, I don't know if you want to comment about Polidocanol versus STS in terms of pain of injection, because I understand that Polidocanol was initially, apart from being used as a detergent for lenses, it was also had a local anesthetic properties. So there's a perception that the injection of Polidocanol is painless and the injection of STS is painful or not so painless. What's your view on that?
Yeah, it's a story that we hear, have heard many times. Polidocanol, another name for polidocanol is lauramacrogol,
Yeah.
and you will find that in quite a few topical creams that are used for the skin, particularly, where one of its functions of including is for local anaesthetic or topical local anaesthetic action. So there is no doubt it has some local anaesthetic action. But then benzyl alcohol also has some, which is a preservative in STS, has some local anaesthetic action as well. So I think at the concentrations we're using them at, those potential local anaesthetic actions are probably going to be fairly minimal, if at all relevant.
Yeah.
And I think, having spoken to enough practitioners who've used both products, they would say that they wouldn't notice a difference necessarily. It's the technique of injection which is more important than the solution that you're injecting. Because if you think about it, you're injecting this directly into a vein, which has very little, if any, in the way of nerve endings within it. Obviously, there are some in the surrounding soft tissues if the solution should leave the blood vessel or leak for any reason. But I think that argument is very difficult to support one way or the other for each of the products. Personally, if you've used both, I mean, do you have an answer to that?
I don't really. I mean, to be honest, I think that the most painful, there are two painful aspects of microsclerotherapy. There is the actual needle insertion itself, and I find that sometimes the 30 gauge needles, which I use, I know we're going to come on to that in a moment. I use 30 gauge needles. They get blunt very quickly, so you do need to change them frequently after 4 or 5 skin punctures. The other thing is that they're not, you do get a dud in the box sometimes. Sometimes I'll change the needle and it's actually more painful, so I have to change it again. So the needle insertion is sometimes painful. And I think extravasation, if you don't inject accurately and you get a little bit of solution outside the vessel and under the skin, you form a bleb. That's uncomfortable, that's painful.
Yes,
In a sense, that's quite reassuring, that if you do get a little bit of stinging, it's not dreadfully painful, it's just a sting that you wouldn't expect. If you do get a little sting with STS or any sclerosant, it's reassuring. It alerts you straight away to the fact you're outside the vessel and you should stop. Any injection that's painful, you should stop straight away. So I personally don't find that, though. I did a chat with two colleagues that's also posted on YouTube, and they have moved away from sodium tetradecyl sulfate to polidocanol for the reason that it's more comfortable. The injections are less stingy. I'm not sure. I've not noticed any difference myself.
No.
So I think, is it fair to say that we should regard them as roughly equivalent at the appropriate doses and concentrations? And you wanted to say something about the sorts of concentrations we should use for vessel size. I think you've given me a nice little chart, which I will put up on the screen in due course, but you've got a suggested comparison chart which gives concentrations for each, haven't you?
Yes, the chart comes from the European guidelines.
Yes.
That Edouard Rabe was the lead author on, published in 2014. I gather they're being updated currently, although I've not seen any sight of the the updated version, and that may have been put on hold because of recent events. But it's well recognised that is what everybody really should be aiming to use. So for spider veins, telangiectasia, for STS 0.1 to 0.2%, for Polidocanol 0.25 to 0.5%. The concentrations at that low level, you can't necessarily really halve the Polidocanol concentration, because in Europe at least there isn't an exact half of that, but that's the best relative concentrations. For reticular veins, 0.5% STS and 1% Polidocanol. And then as we move into the larger varicose veins, then we'd be talking about 1% and 3% STS, and then 1, 2, or 3% Polidocanol, because depending on the market area, there are those concentrations available. So roughly speaking, you should always halve the Polidocanol concentration as an equivalent for STS, and that's as long as you adhere to that sort of protocol, then you shouldn't encounter any difficulties. And it should always be determined by the size of the vein, and that's ultimately what determines the concentration of sclerosant that you use, regardless of which veins you're treating.
And the volume, should we just inject as much as we can? Or I think there's a bit of science that tells us how these detergent molecules are inactivated, and whether we should find a juicy vein and inject as much as we can and blanch the whole area, or whether we should inject a small amount frequently. Can you comment on that, Richard? Yes,
of course. That's very important. Back in the day, when George Fegan was developing his compression sclerotherapy technique, he was a person who actually appreciated that it was important how you injected the sclerosant into a vein. Although he didn't understand what we now understand, if you look back at his publications from back in the 60s and 70s, he understood that it was very important that you do maximize the contact of the sclerosant with the vein, but also treat very small areas at a time. And now we understand why the reason for that is. Going back a little bit as to what I was saying before, how sclerosants work. When you inject a sclerosant into a blood vessel, like it or not, there's going to be some blood cells in there as well. And the sclerosant will have exactly the same effect on the membranes of the blood cells and the proteins within the blood as it does on the endothelial cells. And when there is blood present, because the detergent is working on those blood cells and the proteins in the blood, as well as the endothelial cells, it's going to run out of oomph eventually, and it's going to get used up, so that it can no longer be effective on anywhere else in the blood vessel. And a number of people over the years have looked at this phenomenon. Courage Parsley started looking at the effect of plasma proteins on the efficacy of sclerosants. Mike Watkins from STD did some more work on whole blood and STS, and then Mark Whiteley's group from Guildford in Surrey sort of repeated that work on using whole human blood to do it. And the conclusion is that it takes around about 0.3 mils of blood to inactivate 1 mil of 3% STS. That's the strongest solution. So if we scale that down to what we're looking at in the very small veins, it's going to be a very small amount that's going to be deactivated by the blood that's present there. And one issue that many people, when they start doing microsclerotherapy particularly, notice or have an issue with is the cannulation can be a little bit tricky to begin with, because they're very fine veins, as we've already talked about, and they are quite close to the surface of the skin. And they rejoice when they've actually cannulated the vein, and they can even see a little bit of flashback of blood in the end of the syringe. And they think, all right, I'll just keep injecting that. And they inject into the vessel they're in, and they rapidly see the sclerosant traversing through the network of spider veins and then blanching because the blood's been removed from them. But the chances are, by the time it's reached those outer echelons of that tree of veins, it will be inactivated. And
Right.
so it's just displaced the blood, but it's not had a
Yes.
sclerosant effect on those blood vessels. And so
Right.
not surprisingly, when the patient returns a few weeks later, those veins remain patent and the blood still flows through them. So the general recommendation is, when you're treating spider veins, is that you, in the UK, I always say a 10 pence piece, but if we're talking internationally, we would say about 20 mm diameter,
Mm.
and no greater, because the chances are anything that's out with that circumference will be inactivated. And so it's better to treat a small area systematically, then move on to another area. And that's down to the fact that the product would be deactivated outside of that sphere of working.
So following on from that, some might argue that actually foam would be a better bet, because foam actually physically displaces it. It doesn't get diluted,
Yes.
and it forms a wave of sclerosant that actually physically displaces it. So at the ends of the foam solution, within those two ends, you've got foam solution that's acting on the endothelium, and it doesn't disperse quite so quickly. So some of my colleagues and some of the discussion groups I participate in, they say, well, I inject foam into everything. Now, I'm going to have to say I don't. I'm concerned about injecting foam through a 30 gauge needle. Does it actually change the physical properties of the foam, and is it going to be active as foam? And is there a temptation that you might actually get blanching with inactivated air bubbles? Well, what's the scientific view on this, Richard?
Okay. I have to say it's very popular, especially in France. France is one of the countries where they do. I mean, well, sclerotherapy in France is probably the largest amount of sclerotherapy procedures undertaken anywhere in the world happen in France.
Wow.
Because it is just one of those markets. Because patients in France go to see their well, it's a phlebologist in France is who they go and see. Will go and see their phlebologist like they go and see the dentist. Every 6 months, they'll go for a little bit more treatment on their legs. And that's just a practice that they do. Yes, I mean, it's the rationale for using foam in the larger veins is quite clear, because it's going to, in that cohesive front, it's going to displace any blood that's present in the veins, maximize the contact of the sclerosant with the inside of the vein against the endothelial cells. So we can quite clearly see why that's going to be a large advantage. When we scale it down to the small veins in the spider veins, we're talking overall vein diameter of 1 millimeter, and the internal dimension is going to be significantly less than that. It's such a small volume of space. It takes a very small amount of liquid to rapidly fill up that space. So 1 or 2 drops, which is about 0.1, 0.2 mils of injection, will fill up a sizable amount of a spider vein. So many would argue that there isn't a great advantage using liquid over foam for the small veins. That said,
Foam over liquid, you mean?
Yeah, foam over liquid for the small veins.
Yes.
That said, as I said, many practitioners, as you say, many practitioners do use it as foam. Currently, there is no evidence to support the use of foam in the lower concentrations, and that's why there's nowhere in the world I'm aware, certainly for SDS, that it's licensed in the 0.5 or the 0.2% concentrations for use as foam, just because the evidence doesn't exist and has never existed. There is a trial ongoing in France at the moment where they are comparing, for Polidocanol and SDS, in fact, foam versus liquid for treatment of the spider veins. So it is still progressing, and I don't know any interim results or anything from that. But that will certainly help, or go some way to help explain whether foam is better than liquid or vice versa, because we genuinely don't know the answer.
We genuinely don't know.
The biggest thing we would say about using foam, whatever vein size you use, we know that the use of foam, regardless of whether it's Polidocanol or SDS, is associated with a higher incidence of neurological complications, largely as a result probably we think of the volume of the gas that you're injecting into the patients. So if you inject foam as in terms of microsclerotherapy, then you run the risk of a greater incidence of neurological adverse events. So those are things like headaches, migraines, scotoma, so the aura that precedes a migraine, and at very worst, things like transient ischemic attacks, or at the very pinnacle of those adverse events would be a stroke. We know that from work that people have done within the larger veins, is that patients who are prone to migraines that have probably also got a patent foramen ovale in the heart are the patients that are more likely to experience those sorts of side effects from the use of foam. There is another school of thought, certainly from the Italians, from Frullini in Italy, that would say that it's not the foam at all, but it's the endothelin one that's produced when the endothelial cells necrose. That's a very, very powerful vasoconstrictor. And clearly that's going to get into the circulation and enter into the cerebral circulation and may be responsible for some of the neurological adverse events. Nobody knows the true answer as to exactly what causes it. But I think it's possibly a combination of the two, but probably the air volume is probably more important. So where there is no clear benefit of using foam, I think, again, if you were in the court of law and the right honourable gentleman was saying, well, why did you use foam? How can you support that? Then you'd be on a very sticky wicket if it came to that.
Yes, I agree. Needle size. Do you have any comments about needle size? I've already declared that I use a 30 gauge needle. Am I doing the right thing, Richard? Should I be
Yes,
using
I mean, I think given that the caliber of the veins that you're injecting is very small, then nothing's larger than a 30 gauge. So 30 gauge is where most people would start. 31 gauge is another popular size that people use. And I've even heard of people using up to 35 gauge needles,
Wow.
which with my aged eyesight, I think I would struggle to see even with my glasses on, actually, very, very clearly. I think you'd have to draw the line somewhere. What many people do often also when they're using a traditional needle on a traditional hub is they may also make a slight bend in the needle.
Yes.
I know from working in hospital when I was giving blocks using bupivacaine in people's mouths, we used to bend the needles frequently to actually manage to get them in the right place. I used to get a slap from the theatre sister because we weren't allowed to bend needles in hospitals because the risk of them breaking at the hub. And the finer the gauge needle that you use, the greater risk of it breaking in the procedure. So yeah, 30-31 gauge, I think for most people, they would find that adequate. What we do know from feedback from people who do a lot of microsclerotherapy is the type or the brand of needle is very important, because most traditional needles have just a very plain bevel at the end. And I'm not even sure what angle that's at. It's probably about 30 to 40 degree bevel at the end.
Yes.
Those do tend to blunt quite quickly.
Yes.
Because all they've got at the end is the very tip of the needle, and you've got someone with leathery skin,
Yes.
then that very fine tip is probably going to bend over. So next time you try and use it, it's not the tip of the needle, but it's the bent over tip that you're trying to inject.
Yes.
So we tend to recommend mesotherapy needles because they've been designed for the mesotherapy process that is not popular in the UK, but certainly in many European countries is popular.
Right.
They're designed with a sort of slightly engineered bevel, so it's a multifaceted end of the bevel, so it's not just a plain angle at the end, which probably gives it some slightly increased mechanical strength, although I don't know that anyone's proven that scientifically. But they will tend to remain sharp for a few more than half a dozen injections anyway. They would maybe 10, 15 injections.
Yes.
At the end of the day, you'd expect to get through a few needles in a session.
Absolutely.
That tends to be what many people do use is a Mesarelli needle or a mesotherapy needle.
Right. Okay. Well, I'll ask you for a chart of that, and then I'll show that on the video, perhaps later when I come to do the video editing. Syringe size. what's the, I know that there's a bit of physics behind it, and people say you shouldn't use a 1 ml syringe. Some people say, oh, it doesn't really matter. But you certainly, the consensus is the smaller the syringe, the more likely you are to inject at too high a pressure. Is there any science to back that up? Are there any trials to say, yes, that's the right answer, or is it just anecdote, do you think, Richard?
In terms of size of syringe for microsclerotherapy, I'm not aware of any scientific experiments,
No,
not
no,
good quality ones that have been
no.
published. We would always, or I would always tell people, when you start off, it's possibly better to use a 2 ml syringe. A couple of reasons for that. One is that it's a little bit more comfortable in the hands,
Yes.
which is quite important when you're starting off. And secondly, as you say, that the pressure from the plunger of a 2 ml syringe is going to be significantly less than it is from a 1 ml syringe.
Yes.
And one thing that can happen when you apply too much pressure when you're injecting, because many of these veins are really quite delicate veins, and they're probably not always whole veins at all. There may be some quite immature veins that probably haven't got the traditional 3-layer structure in them, and there's a risk that you will extravasate some of the sclerosant solution, as we talked about before, which isn't going to be, at that concentration is not going to be catastrophic for the tissues, but the patients will know about it because it'll be uncomfortable. So just to reduce the pressures and perhaps make it easier. That said, many people who do microsclerotherapy do lots of other cosmetic procedures where they're quite familiar with using 1 ml insulin type syringes, and will be quite familiar with it, with the way that they feel and so on. So at the end of the day, I would always say use what you're comfortable with. Try a few different types or combinations of syringes and needles, and then stick with the ones that work for you. And
absolutely,
it's the same, I think, for any interventional procedure. Everyone has their favorite instruments. They have their favorite, disposables, and you use what works for them, really.
Yeah, that's right. Side effects. Is there anything we can do in terms of sclerosant, injection, aftercare to mitigate some of the side effects? Obviously, we could talk very briefly about intra-arterial injection. I always say to people that I'm teaching microsclerotherapy to, only inject what you can see.
Yes.
Don't go digging, particularly for reticular veins. Don't go hunting. I think that the area around the ankle is a dangerous area, particularly if you are inexperienced. And there is some suggestion that the back of the knee, the popliteal fossa, is particularly prone. I think in terms of our intra-arterial injection, there are two aspects, aren't there, Richard? There's the actual, you put a needle into an artery, which is a disaster. And then there's, you put a needle into a vein correctly, but some of the sclerosant has got across the circulation from the venous bit into a small arteriole. I think those are the two bits. But in terms of what we do aftercare and what we're injecting and how we're injecting, are there any things we can do to mitigate those problems of pigmentation, phlebitis, matting, the possibility of arterial injection? Do you have any advice to newcomers or even experienced people like me? Fortunately, I have to say, I have not injected into an artery, but I probably have had a little bit of solution go into a small arteriole with a little bit of a blister, but fortunately, again, I've not had this severe vasculitic reaction that occurs with the sclerosant going into the arterioles. So what do you think, Richard? What's the advice?
So yeah, you're quite right. The first thing that I tell everyone is, don't go below the malleolus on the ankle. That's your anatomical limit, because beyond that, then even the superficial veins will start to follow the arteries. So yeah, steer clear of well clear of that. And if a patient demands that they have treatment there, is recommend a practitioner down the road for them to go to, rather than
ankles and feet, stay away from.
Run the risk of treating those. If more experienced practitioners did start to want to stray into those areas, then you should have at least a duplex ultrasound of the region that you're working in, that's done real time immediately before you inject, so that you know the vessels that you see under the skin, which one's the artery, which one's the vein, because the consequences are catastrophic. And the reason it's catastrophic is if you inject into an artery, exactly the same thing's going to happen as you inject into a vein. It's going to interact with the endothelial cells of the artery and the blood cells in the blood vessel. The key difference is an artery is carrying oxygenated blood to the tissues distal to it. And as soon as that oxygenated blood supply is cut off, then the tissues become ischemic and will adversely undergo necrosis, and you can have, essentially you've got an infarction of, could be the toes, could be the whole foot. And there's plenty of pictures published online where if you want to scare yourself, you can go and have a look at them. So it is really catastrophic, and because it's such a rare occurrence, thankfully, there isn't any evidence-based protocol to how to overcome it should it actually happen to you. And it could happen to anybody, even the most careful of people. It could happen. Courage Parsi did a series of cases a few years ago, published, and again summarised that there wasn't any evidence-based protocol for it, but did suggest that if you do suspect that you've injected into an artery, is straight away you give therapeutic anticoagulants, high dose steroids. Be very careful with compression, because you may be actually compressing the only remaining blood supply to the structure. And there are other people who may suggest you might go for hyperbaric oxygen therapy to try and increase the oxygenation of the tissues, but basically nobody knows, but you've got to do something. So avoiding it is the best solution. So keeping away from those anatomical areas. If ever in doubt, duplex ultrasound to check the vessels that you're injecting into, because the beauty of that is you can see the speed of blood flow, and you can quite quickly identify whether it's an artery or a vein you're injecting.
Yeah, so, these would be for bigger veins, weren't they? Would they? For reticular veins? I suppose telangiectasias, you couldn't really inject those under ultrasound. No. Pigmentation, thrombophlebitis, matting. Anything we can do? My mantra is inject slowly, low pressure, small volumes, and very low concentrations. Is there anything else we can do, Richard?
Well, if I read the true answer to that, then I probably wouldn't be working here. I'd probably be selling it by the bucket load. But I mean, the first thing always to say, and it's something that whenever I'm talking to anyone about microsclerotherapy, is like any procedure, you have to warn the patients in advance that these are, common, reasonably common adverse events that can happen after sclerotherapy, regardless of what agent you choose to use. So forewarning the patient is always better than talking to them after the event. So that's the first thing. Good technique, there's no doubt about it that good technique is important in microsclerotherapy, and that will generally, for most people, reduce the incidence of some of these events occurring. So first of all, is choosing the right concentration for the vein size. That's the most critical, I think. Then the technique. So, as you say, a low pressure injection. You don't want to be injecting in a high pressure system, because as we said before, it's likely to force the solution out of the blood vessel. For particularly pigmentation and thrombophlebitis is a collection, essentially an intravascular clot that's irritant to the patient, and that's what we're doing with sclerotherapy. That's the idea. That's what you're trying to essentially form when you inject it. But you don't want that clot to hang around for too long, because then it starts to irritate. So compression of the vessels after treatment is probably one of the factors that will help that, because I don't think, again, anyone's managed to prove this outright.
No.
But it makes perfectly good scientific sense that if you're trying to get a rotund profile vessel to close up and heal. If it's flat, so that the edges are approximated, the fibrosis has got a shorter distance to travel across, and so you're probably more likely to get success in that. So if you can apply compression straight after the treatment, then you're essentially going to squash the veins, squash as much of the retained coagulum out of the blood vessel.
Yes.
So you're going to reduce the incidence of thrombophlebitis. You're also then going to be removing that coagulum and the red blood cells, which are responsible for a lot of the pigmentation, if not all pigmentation, because the pigments come from the hemosiderin, which is a breakdown of the hemoglobin from the red blood cells.
Yes.
And hemosiderin, as I know from my days in pathology, it does tend to have a habit of spreading quite widely beneath the skin once it's formed. The macrophages tend to gobble it up. It spreads along the basement membrane. It just gets absolutely everywhere.
Yeah.
So the more you can do to reduce the amount of hemosiderin that's around will reduce the risk. It will never eliminate it in everybody. And there is some probably more observational evidence than really good quality evidence, but some observational studies that have shown that pigmentation is more likely in those that have already got a darker skin anyway.
Yes. Yes.
So those of Mediterranean origin, it can be a real issue.
Yes.
And so I would suspect that there probably is an element of melanin in that pigmentation as well, that you will get melanin forming where you've got any sites of inflammation. That's another observation that you will see. If you've got someone with a chronic long-term skin condition, looking around the edges, you'll often see some brown pigmentation because that's melanin because of the inflammation that's present. So the more you can do to reduce the inflammation and the coagulum that's there, the lower incidence I think you'll find of those two observations particularly.
That's great.
The matting is, and again, nobody really knows why you get telangiectatic matting, but it's essentially, to describe it for people who've not seen it, it's like a new collection of spider veins, if you like, but albeit of a much finer caliber. So it looks like a flare of blue under the skin because they're really, really fine blood vessels. And my thoughts on that are that it is just a reactive process where you get particularly florid inflammation. You're also going to then get granulation tissue forming as the end result of the inflammatory process. Granulation tissue, as we know, is largely fibroblasts and endothelial cells proliferating to make new blood vessels, and that's probably what we're seeing there. And why do we get lesions like that in the body anyway? For whatever reason, pyogenic granulomas are quite common on the skin where there's been some sort of trauma. It's probably just a local overreaction to the inflammatory, the healing process, really. And I don't know that there's anything necessarily that you can do to really avoid that, although some people would say that, like we said before, avoiding high concentrations of sclerosants, avoiding high volumes of sclerosants, and avoiding high pressure injection. So it's all down to probably a good technique. You're going to minimize these, but you're never going to exclude them altogether because we expect them to happen in a certain number of cases.
Yes. And I know we've covered the aftercare really, but just going back a little bit, obviously patient selection is very important. And I always say to my trainees before they actually start injecting is make sure you've excluded any proximal reflux that's been treated. And if you've got any large reticular veins feeding into an area, then treat those first. But I think what we've said about the actual injections of spider veins is absolutely right. It's inappropriate amounts of sclerosant injected perhaps with too much force and the wrong strength, usually because it's too concentrated, will cause more complications. With regards to compression hosiery, that's hotly debated. Patients don't like it.
No, they don't.
They, in my experience, they cause more problems really than anything else. Patients are always delighted to get them off. I'm never quite sure whether they're actually wearing them when I prescribe them and dispense them.
Yes.
And they're expensive. Good quality compression even the most comfortable sort, which are not always very comfortable for people who've never worn them before, are expensive. So that's hotly debated, whether we should have compression, what level of compression, for how long, do you wear it day and night, do you take it off? Very, very difficult. We've covered quite a lot, but I think one of the important things that you drew my attention to was the importance of photographs.
Yes.
I think we'll just wrap up really with that. And then if you want to make any other comments, Richard, you've been very generous with your time. I've kept you a long time on a Friday afternoon at the start of the weekend. That's very kind of you. So photographs, photographic records. You pulled out a paper, which I'll put up on the screen, which
I mean, it's the paper I'll mention in a moment is not the the pinnacle of scientific research, but it was an interesting paper, and one that just emphasizes the importance of photographic records, and certainly for anything cosmetic. The human memory is not very good, as we all experience, and patients will remember what they want to remember about what their legs or whatever part of the anatomy you're treating for whatever you're treating them with, but that might not be actually all that clear, and there's a chance they'll come back to you and say, well, I don't think what you've done is actually helped me in any way. And it's also very important to warn patients with microsclerotherapy particularly, is that their legs are going to look a lot worse before they actually begin to look better. And that can take really quite a number of weeks, sometimes as long as 3 months for some people to get really good improvement. And so being able to well, one for yourself, because you see lots of patients and you can't remember what veins were where and what they actually look like, to be able to compare the legs before the treatment and after the treatment, and probably more importantly for the patients, because if you can show them what their legs look like before they came to you for treatments and what they look like today, then they will be a lot more happy, because they'll be able to quite clearly see the differences between the two time periods. And the study that I just flagged up, and I'd not seen a similar study before,
no.
In relation to veins, was one that came out of South America, and they essentially did treatments on people's cosmetic treatments on groups of patients on their leg veins, and they got them back, and I think it was about 3 months after the initial treatment, and they gave them questionnaires looking for their satisfaction, and they found that only 59% of them were satisfied with the treatment they'd received, which I think for most people they'd be a little bit disappointed at that. However, when they showed the patients their preoperative photographs compared to the postoperative photographs, the satisfaction went rapidly up to 95%, because then they can actually clearly see and appreciate the improvement that has happened over that period of time. So I can't overestimate how important photographic records are, and certainly from my previous life, having done quite a lot of medico-legal work, photographic records in a court of law speak volumes, much more than any words can do. And in this environment that we're in, being able to show very, very clearly to anyone who wouldn't want to know, well, exactly what have you done to this patient? What is the difference between when they walked into how they are today? Showing 2 photographs will just sum it up very, very nicely for you.
Yes. No, I think you've made an excellent point. And I did read that paper as well. And what struck me about the paper, as you say, it's a small study of and it's not perhaps rigorously designed in the way to prove the point. But I think of all the papers I've read with regards to microsclerotherapy, such as do stockings make a difference? Does microthrombectomy make a difference? These are all very marginal differences that people go on about. Is sodium tetradecyl sulfate better than polidocanol? Those are sometimes poorly designed because they haven't taken account of the relative strengths, and they've perhaps mismatched the concentrations. But when you look at this paper, the magnitude of difference just by showing a photograph dwarfs all the other things that we might do, whether it's microthrombectomy, whether it's be wearing stockings and so forth. And a colleague of mine, Augusto Sampaio from Portugal, he made the observation that when you treat people with microsclerotherapy, two things happen. Their eyesight gets better and their memory gets worse. And by which he means they see things that they didn't notice before, which were always present. So they sometimes come back and say, "Doctor, you treated my veins, but this wasn't there before you started." They can now see it. It was there all the time. The other thing that happens is the memory gets worse, and they say, "Really, I didn't realize how bad they were." Yes, that is a very good improvement. It's not perfect. I've got brown marks. I might have a little bit of matting, but what an improvement. I forgot how bad they were. So I think in addition to the medical legal aspects that you've drawn attention to, which I think are very important, both the doctor and the patient forget how bad it was. I've been quite surprised sometimes. And as I say, it just helps when you get a complaint that you've caused something when you don't think you really did. Patients see things on their other leg once you treated the contralateral. They become more receptive to. Anyway, I think that's really good.
It's sort of the equivalent of somatization in sort of mental health terms. Once they become aware of something and become obsessed with it. And the only other thing about photographic records for legs is having some identifiable landmarks within the photographic field, because it's very difficult to relocate those the two images, pair the two images up if you haven't got something that's identifiable in the
Yes. I'm going to have to get you back on another occasion, Richard, to give us some advice about taking clinical photographs. So I suspect you've taken a lot in your clinical life. No, but I think the trouble with asking an expert about taking clinical photographs is that you get a standard that's totally unachievable in most people's busy clinical practice. In many ways, you want to ask somebody who's using it regularly in their practice, who knows a bit more than average, and perhaps just elevate your own practice a bit. There are lots of people, for example, who don't take any clinical photographs because they don't know where to start. And of course, my clinical photographs are not expert standard, and they could be improved, but they're good enough for me, and they're good enough for my patients. So I'll perhaps tackle you on that some other occasion. We've covered a lot, Richard. I'm going to have to let you go now because I don't know I can afford your hourly rate. No, Richard, that's very kind. You've been very generous with your time and very generous with your knowledge. Do you think we've covered everything that you wanted us to cover? Is there anything else you think we've left out? That we ought to just...
The only other thing I was going to mention, and I forgot when we were talking about intraarterial injections, as you touched upon, was the small necrotic ulcers that you get in the skin. As a result, we think, again, not proven, a result of a small arteriovenous shunt in the capillary bed beneath the surface of the skin. And most people do say that if you do enough microsclerotherapy, it's going to happen to you at least once in your practicing lifetime. And essentially, as we described before, is going to be a small area of infarction of the skin, where there's been a small arteriole affected by the sclerosant, because it's gone straight from the vein into the arteriole. And we get numerous reports of those over the course of time. Quite how you manage them, nobody knows for sure, but I think a fairly conservative way of managing those is keeping it clean, analgesics, and when the patients can tolerate it, compression. It's probably the best way to get those. They will heal. They will take a few weeks to heal, and will generally leave a little sort of punctate scar in the skin. And they actually look. I've not seen one in the flesh, but I've seen many pictures of them. They look like a punch biopsy, like someone's taken a skin punch biopsy out of the skin. It's almost perfectly circular. Patients don't like them; they're uncomfortable.
They're very painful.
They're an event that can happen, and the patients need to be warned about it, and they need to be managed appropriately afterwards.
Yes, I had a discussion with a colleague a couple of weeks, well, a month or two ago now, I think it was, and there is a prognostic indicator for that complication. It's if you treat a friend, a member of your family, or another doctor or a member of his family. Zola Mazimba was very kind to describe a complication where he treated a GP friend stroke colleague, and she developed a small little punched out ulcer. Very, very painful and take a little while to heal, but the appearance outcome was very acceptable, and her spider veins were cleared up very nicely, but very unfortunate. So be very careful. The only thing I would say is that you've got to watch the needle tip very, very carefully when you're doing these injections, and inject slowly. You want to see blanching of the vessels, but if the injection is painful, or if you get blanching of the skin, then you must stop immediately. And in fact, it's usually uncomfortable. If you're injecting very slowly and gently, you'll get pain and the skin will go white. I have seen it, and a colleague of mine called Kathy McGuinness, who teaches on one of the courses, she's seen it from time to time. What she tends to do is to flick the skin and rub it, and it seems to help dissipate that venospasm, the veno-arteriolar spasm. So she vigorously massages the area, disperses the sclerosant, and just flicks it. But I think you just got to watch very carefully. Great. Well, I think
can seem like a very simple technique to looking at it, but it's all these little points.
Yes.
And if you address those,
yes,
it's going to make your practice a lot more successful, I think, and reduce. You can't eliminate, but you can reduce some of those adverse events.
No, if you're injecting a prescription medicine into the circulation, you're going to have side effects and adverse events. But fortunately, it's a very safe technique, and the complications are usually self-limiting. Intra-arterial injection and anaphylaxis are the two disasters. And if you're prepared for anaphylaxis in a setting where you can get help and administer adrenaline and call for an ambulance, that should be taken care of, as it were. If you can, if you recognise anaphylaxis promptly and get help if you suspect it. And of course, intra-arterial injection, as you've said, avoid it. Don't go around the ankle or onto the foot unless you've got access to perhaps some advanced imaging. Most of your patients will be very straightforward if you follow the advice that you've kindly given, Richard. So thank you very much. I'll wrap up there. Thank you. And if I can think of anything else, I think I might get you back for some photograph chat if you're still amenable. But thank you very much, Richard. That was very kind. Thank you.
You're very welcome. Thank you.
Thank you for staying to the end. In the link in the description below, you can find the download for Richard Oliver's slides. I look forward to seeing you in my next video.